Overview of sickle cell disease, and as Ralph has said, is by Jacqui Bowyer and myself, Caroline Anele. Objectives of this session are to discuss the organization of care, to gain awareness of sickle cell disease, inheritance, the pathophysiology and complications, and understand aspects of management of the disease. In 2018, NHS England reorganized the hemoglobinopathy services in England. And presently we have local providers, or you can say local hospitals, and these are supported by the specialist hemoglobinopathy teams. These in turn feed into hemoglobinopathy coordinating centers, and we have one national hemoglobinopathy panel. The hemoglobinopathy networks are involved in making sure the patients get equity of care, improve their health outcomes, ensure education, for example, what we're doing at the moment, involve users in the service improvement, and support the screening program. They also maintain a local and national hemoglobinopathy register, and they promote research. We all belong to the West London Hemoglobinopathy Centre. This is made up of Imperial, Northwest London, and St. George's Hospital Trust. An overview of sickle cell disease. Sickle cell disease is a condition inherited from parents that affects the blood. It affects the part that makes the blood red, called hemoglobin. It's not infectious, so you can't catch it. It's not malignant or a cancer. It's not witchcraft. It's not punishment, and it's not discriminatory. When we look at our blood, we've got the red blood cells, and the job of the red blood cells is to transport oxygen all around our body. And hemoglobin is that part of the red blood cell that does that. We also have white blood cells, they fight infection. We have platelets, which help control bleeding, and we have the watery part of blood, in which all the cells swim in. What happens to the red blood cell in sickle cell disease? In sickle cell disease, normally the red blood cells are round and soft, and they can go through the vessels quite easily without us knowing that that's what's happening. But in sickle cell disease, when they give off the oxygen, the red blood cell changes from the nice round shape to become a sickle shape, and in that shape they can block small vessels, and therefore oxygen doesn't get beyond that area, and it causes a crisis. Symptoms of sickle cell disease. The three main symptoms are anemia, so that's lack of blood, and it makes them tire easily. Infection, and also pain crisis. As I said before, hemoglobin is the part of blood that is affected, and the normal hemoglobin is usually what we call hemoglobin A. And you usually get one hemoglobin gene from one parent and one hemoglobin gene from the other parent. And so if you have the normal hemoglobin, it will be hemoglobin A and A. However, some people don't always have A and A. Some might have a normal hemoglobin gene and an unusual hemoglobin gene. And the unusual hemoglobin gene and the normal hemoglobin gene is usually called a carrier. So if you've got the normal and the unusual, then you'll be called a carrier. Now, there are up to 1,000 different hemoglobin genes apart from the A. Now, common carrier states are, for example, hemoglobin A and S, and we say that person will be a sickle carrier. If you've got A and C, we say hemoglobin C carrier. Hemoglobin A and D, we would say hemoglobin D carrier, and so on. Now, if two carriers are having a baby, there are different outcomes. And in this slide, we have two carriers having a baby, and each of them is a hemoglobin S carrier. Every time they have a baby together, there is a 1 in 4 chance where the baby inherits the normal hemoglobin, which is hemoglobin AA, a 2 in 4 chance where the baby may inherit hemoglobin A and S, and in 1 in 4 chance the baby may inherit the 2 hemoglobin S genes and get sickle cell disease. And this is for every pregnancy. As we said before, there are different types of genes, and also with sickle cell disease, there are different combinations. The constant is that there is an S in the combination. So S and S we usually will call sickle cell anemia. S and C will be hemoglobin S disease. S and D will be hemoglobin SD Punjab disease, and so on. No two individuals with sickle cell disease have the same symptoms, even when they are siblings. So there is slight differences. And also different combinations produce different severities, as we'll talk about. The epidemiology, usually the highest prevalence of sickle cell disease will be found in those from African or African Caribbean in origin. We also have people from the Middle East, India, and East Mediterranean. In fact, it's found that in West Africa, the incidence of hemoglobin S, or the carrier, people with that are hemoglobin S carriers, are like 1:4. In African Caribbean, we find 1 in 10. In Asians, 1 in 20, and in the Mediterranean or Middle East, we find 1 in 50 to 100. We talked about the variability. So one of the things we find is that the symptoms usually begin around 6 months of age. And the reason for this is that when a baby is born, they are born with a lot of what we call hemoglobin F. We like to make it simple and call it baby hemoglobin. And as the baby gets older, this fetal hemoglobin level reduces, and usually around 1 year, it's about 1% left. And so the baby, what the baby now has left is usually the inherited hemoglobin from the parents. So for example, like the slide where we showed you 2 parents with hemoglobin S, what the baby would have as predominant hemoglobin would be hemoglobin S, and that's sickle cell disease. So the signs and symptoms may start to show from about 6 months of age. Now, some children are severely affected, while some others remain largely symptom-free. However, even though the child does not experience pain, they may go on to suffer other complications. For example, a child might be having symptoms that might go on to have a stroke. And also we find some combinations are a bit milder than the others. For example, those with hemoglobin SC or S and beta thalassaemia plus might have milder conditions than those with hemoglobin SS. However, this is variable. Also, some children are lucky and the level of hemoglobin F never drops to 1%. It remains high. And so even though they've got sickle cell disease, because they've got hemoglobin F at a high level, their symptoms are relatively mild. We also know that the socioeconomic factors have an effect on this condition. For example, in countries that do not have a health service as good as the NHS, we find that a lot of children might die before they even turn 5 years old. Whereas in the NHS, because of the good treatment and management, a lot of our children live into adulthood and go beyond, go on to become parents and much older than that. Especially we find the hemoglobin S, a lot of them are grandparents. The precipitants of symptoms, we have temperature changes, dehydration, stress, fatigue, infection, and situations where there is low oxygen concentration, and sometimes we don't know why they have the symptoms. Diagnosis. This condition can be diagnosed during pregnancy, and when a woman is pregnant, we usually would screen the woman to find out if she's got this gene for this condition. And if she does, we'll invite her to bring the baby's father along for screening. If both of them are carriers, we'd ask if they would want to find out if the baby is affected during pregnancy, and then we refer them for this procedure, and they can make a choice from there. Newborn screening. When a baby is born, between the 5th and the 8th day of life, we usually, and the midwife would take a sample from the heel, and that would tell if the baby's got the condition or not. We can also test at any age, so anybody can say, I'd like to know my genotype, and can go to the GP and get screened. The different types of tests, so we have the sickle solubility test, we have hemoglobin electrophoresis, or high performance liquid chromatography, or genetic testing. Signs and symptoms of sickle cell disease. Infection is one of the most common problems with someone with sickle cell disease, and this is because the spleen of people with sickle cell disease does not work very well, and so they do not develop good immunity, so they are not able to fight infection well. Hence, people with sickle cell disease have to take penicillin twice a day or any other antibiotic. People with sickle cell disease are at risk of pneumococcal sepsis, a high risk of it, and so any child with any of these symptoms, it's important that they seek medical help before the symptoms get out of control. The other problem is pain. So pain could be at any part of the body, and really a lot of people know sickle cell disease due to pain. It's the most common symptom of children with sickle cell disease. The pain is usually managed with paracetamol or Nurofen, or they could go on to need things like dihydrocodeine, and if all this isn't controlling the pain, they might need to be hospitalized for pain relief. Painful hands and feet. This is one of the most common signs and symptoms of sickle cell disease for the very young. It's usually one of the things we tell the parents to look out for when we go to educate them when the child is first diagnosed. It's painful, and the same management of pain we talked about in the previous slide applies. Splenic sequestration. The spleen is an organ that sits just under the left rib cage, and it can become when the blood goes into the spleen, it might not drain out due to the blockage caused by the sickle cells, and this could be life-threatening. So what we notice is that the spleen becomes suddenly enlarged, and because usually it happens in very young children, they do not have enough blood going around the body, and this could lead to shock, and if not treated early, could lead to death. And so if this happens, we usually would advise that emergency services are called so that it could be treated. If it happens twice, most of the time the spleen will be removed. Strokes is another common condition of sickle cell disease, and it happens in two ways. There's what we call the silent stroke. So in this case, the stroke is happening, but we don't really know that that's what's happening. So they're not outward signs of it. It might be that a child that was, previously performing quite well at school has, begun to struggle at school. The writing might become poor. You might notice that the things just aren't right with this child. It might be a change in behavior or whatever. In that case, it's very important that the teaching staff make the parents aware so that we can investigate. Normally with children with sickle cell disease from the age of 2 to 16 years old, there is a transcranial Doppler scan that is done just to pick out if they have a risk of a stroke, and if they do, we usually would initiate treatment. This could be in form of blood transfusions. There's also the overt stroke, the one that is so obvious. You can just see the weakness. For example, remember the adverts on television. where there's, facial weakness, dropping of the face, the arms, are they able to raise them and keep them there? Speech, is it affected? And then T, time to call 999. So stroke is really an important symptom with sickle cell disease, and where it is suspected, it's very important that emergency services should be called. So other signs and symptoms could be headache, dizziness, confusion, seizures, etc. I'll leave the stroke to be discussed by Jacqui when she presents her part. There's a lot more she will tell you about that. Acute chest syndrome is another problem for sickle children, and it usually presents as a chest infection, or they might tell you it's chest pain, but any of them, or fever, whatever, any of these symptoms, chest pain, difficulty in breathing, increased respiratory rate, shortness of breath, increased pulse rate, coughing, it's important that medical help should be sought, because with children with sickle cell disease, their immunity isn't that good and things can deteriorate quite quickly. Jaundice. Jaundice is another symptom seen frequently with sickle cell disease, and this is because of the rapid breakdown of the red blood cells, and the end products are usually bilirubin, and it causes yellowness of the whites of the eye and sometimes the skin, depends on how lightly colored they are. This would usually pass out of the system with time. But the reason why we usually highlight it when we speak to you about it is because a lot of the children can get teased because of the jaundice, and this is not very helpful for our children. So please, in schools, it's very important to avoid anybody bullying the children or teasing them because of jaundice. Gallstones can also happen in sickle cell disease, and sometimes these gallstones can become infected, or they can block the duct from where the bile drains, and it could be very painful. Usually this is treated with surgery. Slap cheek syndrome. Slap cheek syndrome is a common infection in children, which usually will pass off for a normal child. But remember, a child with sickle cell disease, one, as we said, they're vulnerable to infection, and also the other issue is that if they get infected with this condition, it sort of arrests the bone marrow, so the bone marrow is unable to produce red blood cells, and already this child is anemic, and so they become more anemic and might need blood transfusions. So it's important that if there is a child with this condition, obviously the child would end up being off school for a while, but it's important to make sure that parents of a child with sickle cell disease are aware of this, so they can look out for signs and symptoms of this, and if their child becomes unwell, they can at least report, so we know that the child has come in contact with this virus that causes this condition. Problems can also happen with children with sickle cell disease, and it happens in about 3% of children. However, we know it happens more with the adults. Sometimes we found children that have had loss of vision. They might have floaters, blood vision, streaks, or reduced night vision. This needs medical attention. Children with sickle cell disease can also have kidney problems. Their problems range from bedwetting, and this is because the children with sickle cell disease, their kidneys are not able to reabsorb the water normally as the urine gets filtered through the kidneys. Other problem, and because of that, obviously they would frequently go to the toilet, and also they need to drink a lot more than others just to make sure that their blood is not viscous. And so you'd find, because they have to drink a lot and also their kidneys are not able to absorb back all the fluid, they'll definitely get to the toilet more frequently than others. The other problems are that because of the sickling that can happen in the blood vessels of the kidney. It could lead to other kidney problems, and so it's not uncommon in sickle cell disease in adulthood for children and for people with sickle cell disease to need a kidney transplant. And so it's so important that we monitor their kidneys. They also have joint problems. So sometimes you could have the head of the femur could be affected with a sickle cell disease, and also the other joint could be the shoulder joint or the knee joint that could be affected. Sometimes in sickle cell disease, at a very young age, they may need hip replacements because of the effect of the sickling around the joints. Teenagers with sickle cell disease could also be prone to leg ulcers. And if this happens, just think about the effect it could have on their personal, the way they feel, and also the pain that can come from that area. So it's very important to be sensitive to any of the teenagers that has this problem. Sickle cell disease can also lead to delayed growth and development. So it's not uncommon for children with sickle cell disease. Sometimes they can have late development of the secondary characteristics, and also sometimes they may look small. And obviously we would refer to the dietitian or the endocrinologist if they have these problems. As you can see, kidney and sickle cell disease can affect all parts of the body. And also another symptom that they suffer from could be, it's called priapism, and this is unwanted erection of the penis in boys. And if this persists for up to 2 hours, it's a medical emergency, and it's important to call the ambulance and get the child to the hospital. But also it's important to note that before this time, it should be planned for, at least to make the child feel at ease to relate this to a teacher or any of the adults they are staying with. Also, it's important to note that anything that is a chronic health condition can affect the mood of that individual. And so even though a child has come to school in the morning, you do not know how whether they had a pain crisis in the night or that morning before coming to school. And also the unpredictability of sickle cell disease can also affect the mood of a child. So it's important to look at them as a whole. Management of sickle cell disease. Infection prophylaxis, and I've mentioned before that they need penicillin or an alternative antibiotic twice a day. They need pain relief for painful crisis. It's important that the family and the child are educated about the condition, lifestyle, avoidance of precipitants. Sometimes they need blood transfusions for specific acute and chronic complications. We can also offer medication, for example, hydroxyurea. And as you recall when I spoke about it earlier, where there is a high hemoglobin F level, it usually helps to reduce the signs and symptoms of the condition. And so this medication helps to increase the hemoglobin F level. And what we found is that most of the children on this condition, their crisis usually is much reduced. So we don't see them a lot more in the hospital as we used to. Also, there is bone marrow transplant, but it's not a treatment that is entered into lightly. And also gene therapy and also psychology support. When a child is newly diagnosed, obviously it's important to discuss the clinical variability of the condition. We focus on risk of infection, especially when they are younger than 5 years old. So we tell the parents, if they've got a fever or any of the symptoms we've mentioned, definitely they need to be seeking medical help. And even beyond 5, if they've got a fever, the same. We encourage the parents to update their immunizations, and also not just the basic immunizations, they do have extra immunizations that help to prevent them from infections, especially those against meningitis and pneumonia. And as we said before, we have penicillin prophylaxis. We also educate the parents on how to manage them at home for pain and indications for seeking help and recognizing severe complications. Thank you for listening to me.
Perfect. Thank you so much for that, Caroline. That's really good overview. So I think we'll hold off on the questions until the second talk in the patient section is done. Jacqui, are you able to share your screen?
Thank you. It's okay. Am I ready to go? Are you okay?
Yeah, ready to go.
Fantastic. Thank you. Sorry about that. So my name is Jacqui Bowyer and I'm the Community Nurse Specialist for children with sickle cell, and I cover children that live in the boroughs of Brent and Harrow, but also children that live in Bedford as well. And our aim, my aim of this session is just to support, to talk to you a little bit about managing and supporting children with sickle cell disease in school. Caroline's given us a great overview of the condition. You can see what a chronic condition it is that affects, you know, every part of your body. So it is quite complicated, and I appreciate it's a lot to sort of take in. But as I say, we're going to talk about how to manage it really, what practical things that you can put in place within school to support the children with the condition. We'll touch a little bit about COVID and how that's affected these children, and then we've got like a video or a video clip at the end, and then we can do some questions at the end of that. Next slide, please. So Caroline's already spoken a lot about the red blood cell and how that's affected, but she did say about the precipitating factors that can affect your red blood cells, and there's a little acronym of HADIT that affects your red blood cells and makes them sickle more. So H would be for hypoxia, so any change in the oxygen intake to your red blood cell will make them sickle more. Similarly, acidosis, so if there's too much acidity or too little acid within your red blood cell, that's going to make them sickle more. D is for dehydration, and I'll touch on that in a moment, but that is one of the most common complications that causes the red blood cells to sickle, and that pain crises. Infection we've spoken about a lot, but we'll touch on that again and how to manage that. And T is temperature, so things like the weather really affects the red blood cells, and we'll discuss about how we can sort of manage that within school and talk a little bit about stress and the other things that sort of affect your red blood cells. So any sort of things like doing PE can be enough just to cause the red blood cells to sickle and cause a crisis. Next slide, please. So hydration is a big one of the biggest complications, actually, to be honest, and we all know day to day that everybody, regardless of whether you've got sickle cell disease or not, you should be drinking lots of water. But it's really, really important that these young pupils with sickle cell disease remain hydrated, because it reduces the likelihood of them becoming unwell or having a painful crisis. So things that can be done within school, just to ensure that children have always got fresh drinking water available, and I would hope that that they are all bringing water bottles into school, if not one, maybe even two, and they're able to fill them up throughout the day as needed. And ideally, they should be aiming to drink at least 2 litres of water a day. We try to encourage them to drink as much throughout the day when they're at school as possible, as opposed to having to drink lots in the evening, just in case they have problems with bedwetting. If they're able to, and that this sometimes depends on the age of the child, but maybe having the water bottle on their table. So in senior school, it's much easier. They can have their water bottles on the table, but obviously in primary school, sometimes it's more appropriate to have all the water bottles on the, on a different table at the side of the room. But then again, equally, the children will need encouragement to remember to go and drink, and obviously staff need to be aware that these children will need prompting. Similarly, if there's water fountains, if within school, no reason why the children can't use them. but we just need to, make sure that they're working, and obviously that they're clean and they're free from infection, because we don't want them to come home saying that they've not been drinking enough water because the water fountains weren't working. Next slide, please. Obviously, because they're drinking lots of water, they're going to need to go to the toilet more frequently, and Caroline spoke about how the kidneys don't work as well. So basically they produce lots of quantities of very dilute urine, which makes them need to go more frequently. So again, things that you can do in school is to not restrict toilet breaks. Really important that these children aren't told that they can't go to the toilet and they have to wait till the end of class or break or something. If they need to be excused, then they need to be excused. Good practice would be to consider using a toilet pass. So lots of schools have devised like a laminated card that just has the child's name on and their medical condition, that just allows them to, to perhaps raise that card, or so our staff know that, the child needs to be excused. We've already spoken a little bit about enuresis, which is ultimately nighttime wetting, but it can be daytime wetting as well, and it is a really common complication of sickle cell disease, and quite frequently can go up into teenage years, particularly in boys. As I say, it can happen in the daytime, but it's worth considering about when we are not in a COVID environment, and things like school trips are back on. Obviously, if you've got overnight stays, it something that would need discussion with parents as well. And obviously the reason, we're trying to avoid embarrassment for the pupil, really. Next slide, please. So temperature is a huge factor, actually, to be honest, in preventing a sickle cell crisis, and it can become a problem if the weather is too hot or too cold. So if they get, they can become ill and they can have a crisis. So again, things that you can do within school would be to avoid overheating of the classrooms, particularly if they're like porta cabins or mobile classrooms. Just making sure that they're well ventilated, making sure that the child with sickle cell is not sitting by an open window or by an open door. Ideally, they should be placed in the middle of the room, just so they're not, surrounded by any potential drafts, because sitting in that draft for, an hour or a day, whatever, depending on the age of the child, could be enough to cause a crisis. It may be that as the weather gets colder, and I'm very mindful now that the weather is changing, it has become quite cold, it may be more appropriate for them to have another layer of clothing. Often you might find, particularly by the time children get to senior school, they've obviously been living with this condition for a while, and you may find that they've often got like a thermal layer underneath their shirt and their jumper and perhaps their blazer. But it may be that actually that might not be enough, and they may be able to, keep their coat on, or maybe, have a scarf or gloves or something, obviously ensuring that they fit in with uniform policy colours. Avoiding any activities that are outside when it's cold and damp, so like it was earlier this week when it was really quite misty and cold and not very pleasant at all. Things, obviously, if they were doing PE, then it would be better that they didn't do it. So there may be some times when they need to be inside during break times and lunch times, and obviously depending on the age of the child, they may need a friend or someone to be with them. But it's really important that all sort of lunchtime supervisory staff are made aware of these children as well. Next slide, please. So physical exercise, I spoke at the very beginning that we need children to exercise. Everyone needs to exercise. Even the children with sickle cell disease need to be doing some exercise. But even the action of exercise and any sort of physical exertion can precipitate a sickle cell crisis. So within school, we need to encourage children to do exercise and participate in PE. Good tip would be to listen to the child and the parent, because each individual will know their own exercise tolerance level. So for many children with sickle cell disease, they could probably, if you ask them to run around a playground 6 times, they probably would only be able to manage it 2 or 3 times, whereas a pupil, without any sickle cell disease would probably be able to do it quite happily 6 times. So everybody is very different. Important if the child says that they're not feeling very well, or they're tired, or they've got pain, that they might just need a little bit of time out, so they might just need to stop, have a little bit of a rest, take some water on board, and they may well be able to then join in afterwards. I think the most important thing would be just to ensuring that they are included within the lesson. So even if, you know, they're perhaps not having a great day and they have got pain, perhaps just allowing them to sort of help with organisation of the lesson, or refereeing, or setting out equipment, keeping scores, those sorts of things, so they're still included. Again, if it's cold and they are, you know, it is cold but okay enough for them to be outside, it may be that rather than wearing perhaps the shorts and t-shirt, that they're wearing their jumper and probably long, you know, jogging bottoms as well. So certainly if it's raining and really windy and damp, then it would be more appropriate for them to not be participating in outdoor PE. And really it's just about following any specialist advice. If you're concerned about their sort of exercise and stuff, then by all means just contacting the specialist medical teams. Next slide, please. So swimming. So some people think if you have sickle cell disease you can't go swimming, but that isn't true, you can. But obviously again it can become a problem, and the problems really become when if they're swimming in pools that aren't very warm, or if there is a delay in drying off afterwards, which we know children often dilly-dally and slow getting dry. So things that we can do to help them would be talking to the parents again and the child about trying to include them in swimming, because we want them to do some activity. Encouraging prompt dressing, and it may be that if they're, you know, in primary school and swimming is part of the curriculum, that you may just need an extra pair of hands. So you might just need another person, albeit a teaching assistant, or sometimes and more often the parent of the child with sickle cell disease will come in to help their child to get dressed, to sort of chivvy them along a little bit. Some schools have liaised with their local leisure centres, because I'm very mindful that not many schools have their own swimming pools these days, and some leisure centres have been able to increase the temperature of the water in the pool to allow the child with sickle cell disease to participate. And similarly, another school actually looked at the timing of the lesson. So often swimming lessons were right at the beginning of the day, but they changed theirs to the end of the day, just to allow the parent then to come in and help. And then obviously the child was then able to go home to their warm house, rather than having to sit potentially in the classroom, perhaps with damp hair for the rest of the day. So just general little things that may just, you know, help, but allow the child to be included as well. Next slide, please. So other things that can sort of relating to exercise really, and huge things for children that transition from primary school to senior school, and they always crop up every sort of September, to be honest. So we all know, we've all been there, and those of you that have got you know, 11-year-old children will know that when you move to senior school, it's very mind-blowing, and it's quite scary and quite daunting. Children are walking from lots of different buildings, from floor to floor, classroom to classroom, carrying a really heavy bag with every single book for every subject that they've got, and even the motion of carrying that bag with all their books, because they don't want to miss out, and they're not quite sure what they need, so they carry it all, can cause a sickle cell crisis. So that action of just the bag. So it's really good practice actually if they have access to a locker that perhaps they can put their books in at the beginning of the day, and they can then go back to a break time, and then similarly at lunchtime, and then after school as well, just to avoid any unnecessary exertion. And also as well, if they're in senior school particularly, if they're, you know, walking up and down lots of stairs, that exertion of walking up and down stairs several times a day can cause a sickle cell crisis. So if there's access to a lift, then, you know, good practice would be just to allow them a lift pass that they're supervised to use, or a lift key. Those types of things are really beneficial. Next slide, thank you. So again, next things we need to do then, obviously if a child were to come to you and say they're in pain, a bit like all of you would do if anyone else would really, you probably take the child away, move them to a quiet area really, but it's about recognizing pain and managing that quickly and promptly, and being mindful that everybody manages and expresses pain in a very different way. So some children may cry, older children just may become quite quiet or withdrawn in themselves, but any changes in their behaviour. The other first things to do would be to offer them some fluid, so encourage them to drink some water, allowing them to rest, as I say, having a bit of time out, giving them some medication. And Caroline spoke about the 2 first-line medications that are routinely given, which is paracetamol and ibuprofen. And I would hope that most parents of children with the condition have signed a consent for schools to give these medications. If they haven't, then please contact us, or certainly we can have a discussion about individual children about ensuring that that is prescribed for them. And any form of distraction, so quiet toys and reading. And it's about then obviously contacting the parent and obviously knowing when to call 999 for an emergency. Next slide, please. So certain things require urgent medical attention, and we've listed a few, and Caroline's spoken about them, but we'll just recap on a couple of them. So any temperature that was over 38 degrees, so that would be a sign that there could be an infection, and that could be anywhere within your body, obviously, because we all know we've got blood flowing everywhere within our body. Pain, so if they come to you and they're in pain, you've perhaps given them some paracetamol, and then you've waited for half an hour or more, given them some ibuprofen, and it's still not working, then they may need more stronger pain relief, which potentially if they came to hospital, the first line thing would be intravenous morphine. If they became breathless, or they looked like they had some difficulty in breathing, or they were complaining of pain in their chest, they're indications that it could be like an acute chest crisis, like Caroline spoke of, and they would be struggling with each breath, sort of to breathe and having pain. If they were complaining of severe abdominal pain, that's a sign, like we spoke about, where they could be having a crisis within their spleen. So the blood's flown into that little organ underneath their ribs, but it can't get out. And again, that can be quite life-threatening. They can drop their hemoglobin level quite quickly. That tends to happen in younger children as opposed to older children, but it can happen at any age. Priapism, Caroline spoke about that, but that's with boys, and it can be at any age. So it can be little boys to toddlers, up into obviously teenagers and obviously adults, but that's where they get a prolonged erection of the penis, and if it lasts for more than an hour or more, it's an emergency. So we would be expecting that child to go to hospital for that, and sometimes they need blood transfusions just to rectify that and get rid of some of the sickled red blood cells. The thing to be mindful around that is obviously, for a child, for a teenager, or any age really, to be honest, obviously it's embarrassing. They're probably not going to tell their parents, let alone staff, let alone us. They don't tell us very often when they come to clinic, even though it's something that's discussed about really, but we do talk to them each time, and it's all about just educating them really, but very important that staff are aware of that, of really. Similarly, if they became drowsy or unresponsive, or if they had a seizure, they would be signs that potentially they could be having a stroke, which obviously you would be then calling 999. Next slide, please. So all children with a medical condition, regardless of what it is really, to be honest, whether it's sickle cell disease or diabetes or anything like that, should have an individual healthcare plan. They are completed by the likes of myself and Caroline as specialist nurses, but sort of generally in conjunction with school nurses and the pupil and the parent. And the idea of them really, it's just a document that shows you how to, it basically gives you an overview of everything that we're discussing and talking about today, about how to keep children well in school, things to do in emergency, pain relief that you might need to give, who to contact, but it also, some of them have a list of staff that have attended training as well, which is always useful for us and for your staff. They're reviewed annually. Often they don't need changing. They just sometimes need updating with use of addresses and phone numbers, that type of thing. And obviously we offer training to all schools, nurseries, colleges. Pre-COVID, we were going into schools doing face-to-face sessions like this, but obviously now, given the circumstances that we're in, we're obviously doing virtual sessions, which has been quite useful as well, actually, because it just allows more people to access it. Next slide, please. So looking at school absences, so children with sickle cell disease, if they're having lots of crises, they can miss several weeks of schooling a year, but more often than not, they actually only miss 2 or 3 days at a time. The majority of children and families with the condition probably manage most of their pain crises at home. It's probably difficult to quantify, but most children probably have a couple of admissions a year. But they could have several, pain, every month, but they don't need admitting to hospital all the time. There were some studies done by a university in Leicestershire, de Montfort, that do all the psychological sort of support and documents for sickle cell and managing children in school, and they found that children with the condition didn't feel that supported. So I'll talk about it in my next slide, but they talk about implementing the healthcare plans and things like that to try and aid support. Very few pupils have attendance levels that are below the government guidelines, and I'm very conscious that in senior school attendance, is key. But for some of these children, they will have lower attendance levels than, other pupils because of their condition. But really important that these pupils with sickle cell disease are not mislabeled. So they're not seen as being truant or lazy or just can't be bothered. They're living obviously with a chronic condition that is very variable and changes, day to day. So it's really important that they're not mislabeled at all. Next slide, please. Thank you. So things we can do to support absences or try to minimise them would be about having the frameworks in place, really. So it is having a school health plan that we know we can work with. It may be that the child, if they're perhaps off school for a few days, or actually they've been admitted to hospital, but they're still, they're getting better, but they're still not able to return to school. It may be more appropriate actually if they've got some work that can be sent home to them, and that can be sort of, that they've given the work, or could be some online work, which they're all got used to this year particularly. It may be that some schools have offered twilight catch-up sessions as well for children that have missed several lessons actually. So just really the whole purpose of that would be then to to ensuring that the child reaches their potential, helps them to catch up really, and sort of detracts from any sort of attention of them being absent. Next slide, please. Thank you. So Caroline spoke about stroke, and we don't mean to scare you, but I think it's really important that we do discuss it again. So between the ages of 2 and 10, children particularly with 2 types of the sickle cell, and we're very conscious that there are lots of different combinations of sickle cell, are more at risk of stroke, and it's about 10 to 12% of children with hemoglobin SS and S beta 0 thalassaemia that are at risk of having a stroke. We've already said they are assessed every year. They come to the hospital for a little scan that just monitors the blood flow within the brain. But obviously there are 2 different types of strokes. This would be the fast approach is obviously when you can visually see that somebody's having an overt stroke, so you can see. So the F, like Caroline's already said, is your facial weakness. So can that person smile or has their mouth or eye drooped? Arm, can they raise their arm above shoulder height? Speech, can the person see clearly and understand what you say? And T is obviously being able to dial 999 in an emergency. Next slide, please. Oh. The other sort of strokes, sometimes they're called silent strokes or transischemic attacks. So they would present themselves in a different way, and it may be that you don't notice anything overtly, you can't see anything happening, but it could be that there's some neurological change going on, and that could demonstrate itself in any sort of changes in their behaviour, or any changes in their concentration or attention. So perhaps they might not be able to concentrate for the whole 45-minute lesson, for example. You might find after 30 minutes or something they're getting a little bit agitated, those sorts of things. And similarly, if they had a sudden deterioration in their work. So that could be handwriting, it could be their grades. So you might find that perhaps, you know, they got their predicted grades and then gradually their grades started declining. That could be an indication that there's some neurological impairment going on. And you can see at the bottom of the little slide of on the scan, on the left hand side, there's a little white patch that just shows a little area of the brain that has been slightly impaired. So it's had reduced blood supply. And about 1/5 of people with sickle cell disease do have a small area of their brain that has had some damage because of reduced blood supply. So things that we can do within school to try and support their learning. And the reason we're doing that, like I've already said, is to ensure that each child reaches their full potential and they do feel supported. But things that we can also put into place would be trying to avoid unnecessary stress. So exams, we know, are stressful for majority of people. I don't think, maybe a few people thrive on them, but not many. So it may be that these pupils, particularly if they're approaching their GCSEs, they may just need a little bit of extra time for their examinations. They may need rest breaks, toilet breaks, that type of thing, just to allow them a little bit more time. Homework, again, they may need a bit of extra time because you don't know, they could have been fine at school, but then on the walk home, particularly if it was damp and it's getting colder now, that could be enough by the time they get home. Later that evening, they could be in pain. So they may not have had time to complete all their homework. So it's just about ensuring effective communication and making sure that's always open with the parents. And hopefully, perhaps some parents might write in their school planners and things like that so that they know. And they can explain to you how the child's been. And there are a few children with sickle cell disease that may need a little bit of extra support. So a few children will need an EHCP, so an educational healthcare plan, for extra sort of one-to-one support. And generally that's the children that have some sort of severe neurological impairment, so some reduced blood flow to the brain that is really beginning to impact on their learning. Next slide, please. It's important to talk about their emotional well-being, and I know Caroline and myself are both quite passionate about this because I think it's an area that sometimes gets lost. Sickle cell disease, as you've heard, is a chronic condition. It is very variable, so day to day it changes. Like I've just given the example of walking home from school, could be fine, might not be. Could be that Christmas is approaching, the children are getting excited. The excitement and the adrenaline that's going around could be enough to cause some sort of more physical exertion, which then could result in them having a crisis. So just important to bear that in mind. Could be that it's a condition that they don't know very much about themselves, and again that depends on the age of the child. All they may know is actually that they just get some pain, and if they do, they just get given some Calpol or some ibuprofen. And they know that in the morning they have to take some penicillin and they take some folic acid. They may not know the names of them, but they just know that they get taken medicines. But there will become a time when they probably start asking questions and asking their parents why they're taking them. And obviously each time they come to clinic, we talk to them a little bit about their condition and give them appropriate literature for that. It could be a condition that few, if any, of their friends or staff even know about. Sickle cell disease is actually the most commonly inherited condition of all the conditions that you can inherit. So it's about 1 in 2,000 children that are born every year that inherit sickle cell disease. So it's overtaken the likes of cystic fibrosis, which generally I would say the general public know more about and have more awareness of than sickle cell disease. But similarly, the population that we're dealing with generally tends to be Black African. There's a lot of stigma that unfortunately still exists today. So within the culture, you know, we often have many families that actually don't tell their extended family that they have a child with this condition because they feel like they've been cursed or some sort of witchcraft has made them be punished, and they've been given a child with this condition. So cultural impact is huge. So obviously then, you know, any of those things, and if you're living with a chronic condition or chronic pain, it's going to affect your mood and your mindset really. So things that we can do within school just to ensure that the child has a key person that they can talk to in school. Sorry, Ralph, I can't see the bottom of my slide. How can I get rid of that?
Sorry, which element can't you see?
Can't see the bottom of it. I can only see the first line of the having a person to talk to.
Okay, so the other ones, I can see the others. I assume they're going out. Encourage a child to tell a few friends about their condition.
Oh yeah, fine. That's okay. That's okay. I can just talk.
Counselling.
That's fine. So yeah, obviously having somebody in school that they can talk to. Sometimes it's a good idea to encourage a child to even just to tell one or two of their friends. I've spoken to it before that actually I've had a few children where they've gone into perhaps year 7 or 8 and they wanted to tell a few friends about their condition, or why they might have been away from school for a few days, or they can't quite manage to keep up in PE. It's what they've then done is actually one young girl actually was very brave and decided to stand up in front of the class and tell them a little bit about herself and her condition, and I just went along to support her with that. Really, it was actually she was very brave, and actually it was a very emotional thing to do. Obviously some children may need school counselling, but again I'm mindful, that's obviously quite oversubscribed counselling, and often funding can be an issue with that. But we do all the specialist teams, so all the children that come to the hospital, we do have psychologists within our team that there's always somebody that they can talk to. But if you're concerned about a child's emotional well-being, then by all means get in contact with us. Next slide, please. So just to talk a little bit about COVID, because I'm mindful it's been a very challenging year for everybody. So prior, at the beginning of the year, when we first became aware of COVID, all the children with sickle cell disease were encouraged to shield. So they weren't in school, they were staying at home for the 12 weeks. But then obviously when the guidelines were reviewed in August, and they've been reviewed again subsequently, the advice was actually that these children could be actually returning to school. There's been lots of research shown, and actually very minimal numbers of children with sickle cell disease thankfully caught COVID, and if they did, it was very mild, and actually as we've seen with children without sickle cell disease, very few children have been sort of symptomatic really. So the advice is really just to follow the general government guidance really of social distancing, wearing face coverings, regular hand washing and sanitizing. As I say, we would expect all children with sickle cell disease to now be back in school. As I say, it's only a very few of our children that are deemed as being clinically extremely vulnerable, and they're a few with severe iron overload. Obviously parents of children with the condition, or if they've got the condition themselves, they're obviously able to return to work, as obviously they've been risk assessed in their workplace, and just generally can go outside, but just following the social distance guidelines really. Next slide please. So now I'm just going to hand back to Ralph. Thank you very much for listening. I'm sorry for my IT incompetencies, but we're just going to hear a little excerpt of a video of a young person who has sickle cell disease, and then we can take some questions afterwards. Thank you.
Thank you, Jacqui. I'll just play the video.
Time to wake up, relax.
I have sickle cell anemia, which is one of the sickle cell disorders.
Okay.
It's a difficult thing to understand about my condition is the fact that there are no visible signs. So if I say...
Excuse me, is it possible you can put the subtitles on, put the captions on?
I think sometimes when you don't see something, it's very difficult to believe it. And having a blood disorder, like my condition is, it's so... You can't see anything because it's in the blood, and even if you are in a lot of pain, because there's nothing really visible, is very hard for people to grasp. I think the most distinctive thing about my condition is the way it can be so unpredictable, because I can wake up and feel great, or I can wake up and I'm not really sure how my day is. I can wake up and feel really bad, or I can go to bed feeling great and wake up feeling in a lot of pain. It's just very unpredictable. Sickle cell, it's genetic, so you can't catch it. And I inherited it from both of my parents. My mum and my dad are both have sickle cell trait. So I inherited sickle cell disorder because of their genes. And what it does is it changes the shape of your red blood cells. So whereas most people, their red blood cells are round, mine are crescent shaped or sickle shaped. Hence. And because they're shaped, they can get caught amongst each other when they're in small capillaries. So as your blood is flowing, they can get stuck together. And also the sickle cells are more sticky as well. So it's difficult for them when they are all clumped together to release. And what this does is it causes my body to have a lot of pain. And this can occur in any part of my body and at any time. Having blood transfusions reduces the amount of sickle cells that I have in my blood. The place where I get pain most frequently is my hips. But when I get pains in my long bones and my shins especially, it's a lot harder for me to deal with. It's just very intense, very painful, very sharp. It's like it's under somewhere and you can't dig it out to deal with it. And it just feels like a gentle hammering that kind of gradually builds up till you just can't take anymore. It feels like there's a pressure point and it feels like you're going to snap. It's really horrible, but it does feel like you could just snap. When I have a bad day, it's very difficult actually. I have to stay at home.
Bye, Mom. Bye.
At times, especially like during the school term, you just think about all the things that are going on, how much you're going to have to catch up on. My average school attendance is about 60%. So I'm now 2 years behind going to uni. And the hardest thing for me is when I'm at home and I feel really ill, but I can't do my schoolwork at home. And that I always feel guilty. It's hard to see where everybody else is going and you being held back. That's something that's really difficult to do. I think what I wish everyone to take from me being on this film is just the fact that I really want to be believed, and that it doesn't look like I have anything wrong with me, but I go through a lot.
Okay, thank you, Caroline and Jacqui, for the presentations. Those are really appreciated. Does anyone have any questions just now? Either in the chat or if you want to raise your hands. One thing I was going to ask both of you is how often do sickle cell crises occur within schools on average, or is it very dependent on the pupil?
Shall I answer, Caroline? Sorry. I think it's variable, to be honest, actually, Raoul. As I say, I think it generally often depends on the combination of hemoglobins that you inherit. So, for example, SS, if you looked at all the, if you Googled it, it would come across and tell you it's the most sort of severest form, whereas obviously if you had S and an E, for example, then potentially you wouldn't have as many pain crises. But it is very individual really. So that person that may have, you know, SC, for example, could potentially be worse than somebody with SS. It is just, it's hard to say actually, to be honest. As I say, some people can have pain every month, some can go for 6 months, a year or so without any pain crisis. So it's very difficult to sort of quantify really.
I note Karen Borthwick, you have your hand up. Do you want to unmute and ask your question?
Hi, yeah, I thought that was really good, really useful. We've got a pupil currently in year 7 with sickle cell, and obviously was shielding. And then when we went into the second lockdown, we received a letter from Mum via the consultant that said he shouldn't be in school again. He's still not in school, and we're wondering, should he be in school? Because I don't think, looking at the care plan, he's in that very small minority of, you know, incredibly vulnerable. We've had very few cases of COVID in our school, very few. We've not had to collect so many bobbles or anything like that. I think we've actually had about 4 live cases, so we've done very well as a school. But obviously this is a child who's, you know, not really accessing education very much at the moment. And yes, you can do home learning, but it's not the same. Even if you're doing like via Teams, it's not quite the same as actually being in the classroom, and he does have some additional learning needs. So I just wondered how I sort of address that really, because I feel, I mean, we're nearly at the end of term now, but I feel in January we can't really afford again for him not to be accessing school. What do you think I should do?
I personally think, yeah, obviously we can't divulge any, confidentiality issues of that actual child, but maybe afterwards you can certainly email myself or Caroline. Maybe the child may be one of ours, and perhaps we can just deal with it on an individual basis. I agree with you completely. It doesn't sound like, they should be in school. There is no reason for them not to be in school. You've obviously done a really good job of not, maintaining COVID infections within your school, but maybe just give us, either of us an email afterwards, actually, and then we can sort of help and support you a bit more.
Thank you.
Yeah, and also if you look on that child's care plan, there will be a number there of the specialist nurse. So just call us immediately after the session, and we'll be able to tell you if they're on our caseload. If he's one of those that should be shielding or not.
Thank you.
Thank you.
Karen, I'll forward you Caroline and Jackie's email addresses afterwards. Does anyone have any other questions? Just go have a quick look in the chat. Caroline and Jacqui, do you think you'll be running the session again next year for those pupils when they move up a class or upper level?
I think it's going to be a regular session every few months. We will put it on, and we will definitely send out the information. What we'd love you to do is to send your email addresses to Ralph, so that we have a database of the schools that we can contact, all the school nurses, because at the moment we're doing it individually and it could be time consuming. So it would be nice if we get your details and send the invites out all at once. Thank you.
Thanks. Jacqui, can you think of any particularly exemplary points of best practice in schools?
Oh gosh, put me on the spot, why don't you? I think probably the swimming, the couple of primary schools that adjusted their swimming timetable and spoke to the swimming pool to allow them to do it. And actually another school, actually off the top of my head, this was about swimming as well, actually. So the children used to walk from primary school to the leisure centre, which was quite a way. It was probably about a 25-minute walk there and back. So quite a long way for little people. And actually what they then did, actually, there were 2 children actually with sickle in the school, and one of the staff went in their car, so they didn't have to walk, because obviously if they've walked for 20 minutes or more and then they've got to do half an hour swimming lesson, they're going to be completely exhausted for the rest of the day. So they were very good practices, really. But I think just general awareness, really, of the condition and how it can impact on you every day, really, and just making sure that every person within school, so whether you're a teacher, a domestic, you know, I want to say dinner lady, I don't think, are they called, they're not called dinner ladies anymore, are they? They're lunchtime supervisors, those sort of staff, you know, they all need to be aware, really, to be honest. So we're very welcome, you know, welcome anyone who wants to come and listen to us chat on and on and on.
There was a hand up in the chat from Gloria. Gloria, do you want to ask your question?
Oh, yeah. It's to know about this particular session. Did the video will be sent to the schools? Because I'm not quite sure if all schools manage to attend this session. I'm worried about my daughter's school. I'm not quite sure if they are aware about this session.
Yeah, Gloria, after the session, I'll forward around certificates of attendance, the slides from the session, and also once the video is uploaded on YouTube, I'll forward around the link to its location. So, and that will be to everyone who's registered for the session. We have a question from Amanda Bryden. I'm a newly qualified school nurse and wondered if there are any resources I can create for the team.
Go, Caroline.
So is this the resources for the school or for your school nursing team?
I would say for the team, really. I mean, this has been amazing, and actually I think my question got answered by Ralph, who said, you know, the recording will be sent around and what have you. So, you know, maybe those links can be shared. But I had to admit, I mean, the session was really informative, and I have to admit, I didn't really know a great deal about it myself. So I've learned an awful lot today, and I just, you know, I'm just thinking of things that I haven't necessarily come across that much. And so, something that I can keep to hand and go, oh yeah, I know where that is. That will answer the questions, you know, if there was like a little toolkit.
Obviously the videos on the YouTube help. And also, if, you know, as a nurse, we can also refer you to the sickle cell standards, and there's an executive summary, and you can always, you know, keep that on your drive, and you can log into it, and it tells you a lot about it. So
thank you.
Help.
Yeah.
Yeah. Thank you.
And also actually just yeah, the Sickle Cell Society, they're a very good source of information. The standards are all on there, and also the if you just Google newborn screening, actually you'll find an awful lot of information on there. And something else that's escaped me actually. It's on actually the end of one of my slides has actually got a list of websites and stuff, and I think there's the psychological one, which has got all the school health care plans on there. That's a very good source of information.
Wow, brilliant. Yes. Thank you.
Is there one specific leaflet, this is from Alison Simpson, that we can give to teachers summarising the needs and support?
Yeah, Simon Dyson's document, which is the school care plan, actually. So that is on that link is on my presentation, Ralph.
Yes.
Perfect. As I said, I'll make sure the presentations go out to everybody who registered.
Yeah.
Okay, are there any other questions? Okay, in that case, I would just like to thank Jacqui and Caroline for your excellent talks. It's really appreciated you taking the time to do this. And thank you everyone for attending today. That too is also extremely appreciated by the network in West London. And we hope you've all enjoyed today's talks. As I said previously, all the information will be sent around afterwards, and we'll also forward on a survey asking you how you found the session. So if you could complete that for us, that would be really appreciated. Okay, thank you everyone, and stay safe.
Thank you very much.
Thank you.
Thank you.
Thank you.